So I guess we can give the first case to a Turkey. Hold on. So this is a Turkey. This is a 62-year-old woman with heavy history of smoking that presented to the ER with an outside hospital ER with upper back pain. So what other questions would you want to ask?
Hey, good morning, Eva. Yeah, so I want to ask if she has been, losing weight, any radiation of the pain to the legs, for example, any
Mhm.
weakness, any sensory deficits.
Okay, yeah. So no real weight loss, and then no radiculopathy, and then no like bowel or bladder incontinence or anything like that. And so here's her exam. And so what imaging would you want to get first?
So initially, I would get a CT scan
Mhm.
of the thoracic spine, since it's the upper back.
Yeah. Okay, so yeah, so at the other outside hospital, they ended up getting, a CT. I don't have the CT, but and they got an X-ray, and so it showed this, the right lung lesion, and then on the CT of the thoracic spine, it showed a T5 compression fracture, which they ended up doing a kyphoplasty on, which I don't have the imaging for. And so now that you see this, lung lesion on the right, what would want to get now?
Yeah, I mean, I would do a metastatic workup, so
Mhm.
CT, chest, abdomen, pelvis. Um, and for that, I would just go there with the CT chest abdomen pelvis and see if she has any metastatic disease elsewhere.
Mhm. And would you also get like imaging of the rest of the neuroaxis or just?
Yeah, I mean, I would get a CT of the lumbar spine, because only CT thoracic spine was done, right?
Yeah.
Yeah, so I would get that because the T spine CT didn't show anything except the fracture that was repaired with the kyphoplasty.
Okay. So they ended up also getting a CT of the head, which showed CP angle lesion, and so then they ended up doing an MRI as follow up. And so on the MRI, here's what they see. Can you describe?
Yeah, yeah. So this is we have an axial MRI with T1 without and with GAD in the image below, and it shows a moderately sized lesion that is contrast enhancing with an isointense nodule in the medial part, and it's isointense on T1. Um, it's causing fair, compression of the pons, and also it has a dural tail um, that extends to the clivus and also to the petrous bone on the right side laterally.
Yeah. And then here's just this, which you already said there. I mean, is there anything else that you see here? Just like this edema, right? So what are the differentials that you think that this is?
Yeah, so given that it's an incidental finding, she wasn't complaining of any symptoms, so I wouldn't think of any aggressive lesion. This could be number one, meningioma, given that it has a dural tail. Also, um, could be a schwannoma, but I don't see any IAC extension. It could also be an epidermoid cyst. And again, least likely the metastatic disease, given that she was not complaining of any cranial symptoms.
Yeah, so that's kind of what we thought. And I found this online. I thought it was kind of helpful. There's like four different ways that you can classify, these lesions. Just like one is, if it's a contrast enhancing mass, and there's certain differentials that go with it, which is some of what you mentioned. And then there's ones that are just high intrinsic, signal on T1. And then ones that are just CSF, density, which are like arachnoid cyst and epidermoid, and then other masses. And so I thought that was kind of helpful. And so now, you had this lady with, what we think is an instantly found, possible, meningioma and a newly diagnosed lung lesion. What would you do with this patient? Would you just observe it? Would you go ahead and treat it, with radiosurgery, microsurgery? What would you do?
Yeah, so I would like to obtain at least a baseline hearing assessment. So I'd refer her to, for audiometry, for analysis, and then I would just observe. I would not treat this patient, given that she's asymptomatic, at least in the meantime. If it grows or if it causes any symptoms, then I might consider my options, whether it's microsurgery versus radiosurgery.
Okay, yeah. So with this patient, because we had thought that it was, probably petroclival meningioma, given, what Turkey had said before. And, there was a little bit of edema in the brainstem, in the pons area. And so we offered elective resection, once her rest of her cancer was treated. And so, then we sent her home. Then 6 weeks later, she developed worsening back pain over the past week, and then a new partial, right cranial nerve 6 palsy. So what would you do now?
Yeah, so since she had a new cranial nerve deficit, I would do a CT scan to make sure there's, any hematoma within that region or any acute finding.
And then what about for the back pain?
Yeah, for the back pain, I would also get imaging, at least a CT, to start with CT of the lumbar spine and thoracic spine.
Okay, so they ended up first getting an X-ray. So what do you see on the X-ray?
Yeah, so I can see there's an upper thoracic severe pathological compression fracture with, kyphosis. So yeah, that's the cause of her back pain.
Okay, so then they ended up getting a CT, and this is from left to right. This is the left on, one side, the middle, and then the right, and then the axial at the pedicle level.
Oh yeah, and I can also see some, hyperdensity within the canal, maybe some extravasation of the previous kyphoplasty material.
Yeah.
Is that a spine? I'm sorry, I'm in action. Is that spine?
Yeah, sorry, I'm doing the presentation right now.
Oh,
Yeah.
sorry.
So then they ended up getting an MRI, and can you describe what you see?
Yeah, so this is a T2 MRI sagittal with axial images of the upper thoracic spine that shows severe, I would say, retropulsion of the vertebral body and compression of the spinal cord ventrally. It's pretty severe compression. And she doesn't have any symptoms, right? No weakness, no sensory deficits.
No.
Wow.
Just hyperreflexia, yeah.
Yeah.
And do you think it's okay? So I'll show you the contrast. Do you think it's still just retropulsion, or what do you think that is?
No, retropulsion with, I would say, some cancer element, given that there's some enhancements.
Okay, yeah. And then do you see, like, here on this right, this axial, it seems to involve the pedicle as well, right?
Yeah.
Okay, so, now they also did a brain, an MRI of the brain because of her new cranial nerve 6 palsy. So what do you see here? So the top is the MRI from, 6 weeks ago, and then the bottom is MRI from now.
Yeah, so there's worsening edema of the brainstem or the pons. And it seems that it's also larger, at least, to some extent. It grew in size, so it's both symptomatic and larger in size. So this needs to be treated. I would offer, surgery for this patient, given that it rapidly increased and could be malignant also.
Yeah. So, so now, you have this patient with this spine lesion and this, brain lesion. So what would you do the spine first or the CP angle lesion first? What's timing of your approach? Like if you are going to offer surgery for both of these, but, would you do the spine or brain first?
I mean, given that she had extensive brainstem edema that is worse in 6 weeks, I would treat the CP angle lesion first. And in the same setting or in the same admission, I would also treat the spinal lesion too. Given that she has only hyperreflexia and doesn't have progression in symptoms, I would do that second after the CP angle lesion.
Yeah, so I think that's reasonable, but they ended up doing the spine first just because they were more concerned, because of severe cord compression. And so they thought that, even though there's edema of the brainstem, that could wait. And so they ended up treating the spine first. And so if you were to do the spine, what approach would you do?
Yes, so I would do, first of all, transpedicular approach, decompress or separation surgery for the spinal cord, and then I would do two level above, two level below fusion, and then radiosurgery or radiation therapy for that lesion.
Yeah, so similar to what you said, they actually went 3 above, 3 below, and then they did it transpedicular at T5 bilaterally, and then went ventrally to remove the tumor from the ventral aspect. And so then for the CP angle lesion, now they did surgery in the same admission. What would you do? Radiosurgery or microsurgery?
No, I would definitely do microsurgery, given the rapidly enlarged in 6 weeks, so it's pretty rapid.
And what approach would you use?
Yeah, for this one, I would use retrosigmoid approach and resect the lesion, and also it goes all the way up to the not to the middle fossa, but to the petrous apex. So this might also need some subtemporal approach to fully resect the lesion. So combine subtemporal and retrosigmoid.
Yeah, so
or could be subtemporal and Kawase approach, just to get the CP angle components.
Yeah, so they ended up actually being able to get all of it, through the retrosig approach, and so we actually ended up consulting radiation oncology before, just because of her cancer history, and she wasn't that healthy of a person, and so we asked them, can you just radiate this? And so they actually ended up wanting to do having us debulk the lesion first before they radiated, given the new brainstem edema and the size of the lesion. And so when they did the retrosigmoid approach, actually when they got to the tumor, it looked like there was 2 different consistencies. So laterally the lesion was gray and suckable, and then medially it looked white and tan, and it was really adherent to the brainstem, cranial nerve 5, and ICA. And so they were only able to get like 85% resection. And so you can see, on the right, the rind of tumor that they left where it was adherent. So then we'll turn it over to Dr. Saad for the path.
Eva, is it okay if I share my screen so I can use my arrow? All right, thank you. Okay, good morning, everyone. So this is the tumor from January 12, 2018. So this is the biopsy from the spine tumor. And you can see this is an adenocarcinoma. You can see the glandular structures at low magnification. And then higher magnification, these are the glands, and the lining is kind of mucinous. So this is metastatic mucinous adenocarcinoma, which was characterized by immunostain as lung in origin. 5 days later, she underwent craniotomy, and this is the tumor. So you can see a biphasic growth patterns. Here you have solid growth, and then you have structures that are similar to the one I just showed you in the spine. So there is definitely metastatic mucinous adenocarcinoma here, but this is the sheet-like growth, and this is a meningioma, and you can see the characteristic clearing of the meningothelial nuclei. And this is higher magnification of the mucinous component that is metastatic into the meningioma. So similar to the spinal tumor, it is adenocarcinoma, and here it is obviously a mucinous. And by immunostain, the tumor cells are positive for CK7, which is a keratin that is very helpful in identifying adenocarcinoma of lung primary. So this is a metastatic adenocarcinoma to meningioma.
Okay, so let me share my screen real quick. Okay, so yeah, so what Dr. Saad said, this is an intratumoral met of lung adenocarcinoma to petroclival meningioma. And so these lesions, should be suspected if you have a new onset neurodeficit in a patient that already has a history of known METs, and also imaging that shows, intracranial mass with intratumoral heterogeneity, which you can see here on the right. Looks like there's a little nodule, inside this otherwise homogeneous contrast enhancement. And so this, I just wanted to point out, differs from like tumor collision. So tumor collision is, when you have just two tumors that are growing, happen to grow side by side. And so you see here the meningioma on the left side, and then just the mucinous adenocarcinoma on the right. But then this is different from tumor to tumor met, which is basically you have a tumor that's metastasized inside the recipient lesion. And so for that to happen, the recipient cells have to be at least partly surrounding the donor lesion. So you see here, it's like at the bottom, the meningiomas, intermixed with the mucinous adenocarcinoma instead of just side by side. So then the next case, I guess we can call on, is Imad there?
Yeah, I'm here.
Okay, so this is a 24-year-old woman who had an incidentally found lesion in 2019 on workup of headache. And so now she presents with blurry vision in the left eye. Here's her eye, visual exam. What would you do?
I would start with some imaging. Probably start with the 2019 workup. I would start with the MRI of the head,
Mhm.
with and without.
Okay. So yeah, they ended up getting a CT, and then describe what you see on the CT.
So in the CT, it looks like she has this hypodense lesion, hypodense space or cavity in the left anterior skull base. It looks like it's almost kind of just air, I would say, considering for like some kind of like empty kind of area, probably like almost like a pneumocephalus.
Mhm. What else can be hypodense on CT other than air? Do you see around here, like on the skin? I don't know if you see my mouse, but what is this?
It
here?
could just be like just like
Like what is in skin? Like fat? So you can also have like fat that can be hypodense as well, right? Or anything kind of like protein. Yeah. So here, so that's what you see. And then on the bottom, I was just showing, it looks kind of, it's not just pure hypodense. It looks like there's kind of some heterogeneity inside that. And so here they got an MRI. So what do you see here?
yeah,
Or list the, these are all different sequences. So you can just say, which sequences they are and what you see.
yeah. So on the MRI, it looks like it's kind of some hyperintensity, almost like a little irregular in terms of the signal that you kind of see.
Mhm.
I would say it's kind of, and on the
Does it
T2,
look like it's contrast enhancing?
I don't think it's contrast enhancing. I
Mhm.
think it's probably something like either like blood or fat
Mhm.
on the T1 because of its of the signal that you see.
And then what are the bottom ones?
So on the T2, let me see. We're looking at a different level, but you can kind of still see it. You see a signal on T2 as well. You don't see it. You see some restriction on the diffusion around the edges,
Mhm.
and on the T1, you're not seeing any kind of
Oh yeah, so this one's kind of hard. This one's flare with fat suppression, so it ends up
you're not really seeing
suppressing. Yeah, and then here I just wanted to point out, on the T2, it looked like it's kind of abutting the left optic nerve, which could be, explaining her blurry vision. And so hold on, let me go to the next screen. So what do you think is the differential? Or
could
bright,
be-
something that's bright on T1 and then, fat suppressed.
yeah, so it could be something of fat origin. It could be like it would be kind of rare, but it could also have maybe like a epidermoid or even like almost like an intracranial lipoma site type
Yeah.
picture too. So
Yeah, and then the other thing could be is a dermoid maybe. And so here, I just wanted to point out on the dermoid from like lipoma, just because we also initially thought it might be a lipoma, but then, you know, on looking at it
Mhm.
on the dermoid, you can see, or okay, I'll just point out for the lipoma at the bottom, you can see here, it's like homogeneous signal intensity throughout, you know, on the CT, then on the
Mhm.
T1 and on T2, but then on the dermoid, it looks a little heterogeneous, you know, it looks like there's like stuff inside. And then on T1 here, it's also, you know, heterogeneous in here as well. And so would you treat this patient, just watch it, you know?
Probably would treat it because she's having some kind of cranial nerve deficit, and especially if it's compressing upon her optic nerve, she would probably benefit from some kind of from surgery.
So I guess is Damien here? Or Sumed?
Hey, Eva, yeah, I'm here.
Hey, what approach would you do for this?
Yeah, so I was thinking to try to kind of get into right where like this, like the planum essentially would be. You could try a few different things. You could, do a terional perhaps coming from the left side to get access there. You may have to do a little bit of a you'll have to retract a little bit of the frontal lobe up a little bit. You could maybe even do like a subfrontal, like a come basically with an eyebrow incision and come underneath the frontal lobe. I would probably more so go with a terional for this one.
Yeah.
And then I guess the goal of surgery would be to try to decompress the optic apparatus. So that's why I'd probably go with the terional for this.
So exactly. So basically diagnosis, decompress the optic nerves, and then possible cure if you're able to get it all. So what they ended up doing is like what Sumed said, who actually went lateral supraorbital approach via terional incision and went subfrontal. And so then the other alternative, like what Sumed said, was you can also do an eyebrow approach with supraorbital craniotomy. I didn't show it here, but there was pretty much no frontal sinus at all. And so they were able to get gross total resection. So we'll turn it over to Dr. Saad for the path.
Thank you. Okay, so this is what we received. This is at low magnification. So you can see that the lesion consists of dense fibrous tissue. I don't know if this is dura, but next to it, you see this dystrophic calcification, and I'll show you higher magnification. So some inflammatory cells, dystrophic calcification, a little bit of early bone formation. And so this is the entire lesion. Now, what it represents, no one can be certain, but any slow growing tumor such as dermoid, epidermoid, even small meningiomas or vascular lesions can undergo dystrophic ossification/calcification, and the exact lesion, is gone. So you're left with all these dystrophic changes.
So I know that the path, I know that the path showed the dystrophic changes, but we thought it was still a dermoid cyst because in the surgery, it looked like there was like keratinized, skin flakes inside that lesion as well as hair, which is what we saw. And so we thought that it was a dermoid cyst, even if the path didn't show that. And so a dermoid cyst is pretty much, it's a developmental anomaly, and it happens. Embryonic ectoderm is trapped in the neural tube, which is closing, and so they secrete sebum, which is what gives it the bright T1 appearance on MRI and then hypodense on CT. And so usually it occurs in midline locations. And so just thought that this was kind of helpful, like classifying epidermoid cyst from dermoid cyst. And so if you look, the immunohistochemistry staining is the same, and it looks pretty much the same on histology, except for it also has adnexal structures, which you see here at the bottom, which it doesn't have on the epidermoid. And so this is the third case. So I guess is Tyler here?
Yeah, I am.
So yeah, this is a 30-year-old who male who had a psychiatric history and presented with altered mental status for the past 2 days. He has a history of syphilis, HIV, uses cannabis, cocaine, and on exam, he's, somnolent, but you can arouse him. He's only oriented to names, confused, and just intermittently following commands.
Oh, sorry. Oh, yeah. Okay. Sorry, go ahead.
Yeah, so what would you
Dr.
do
Wang
for
just
this
walked in,
patient?
but he's letting me finish this
Okay,
case first.
that's okay. No, go ahead. Go around.
Are you sure?
Yeah.
Okay, no, we're going. Dr. Wang says let's do it. All right, here we go. What's next?
Oh, so what would you do?
Maybe like a lumbar puncture. Wait, somnal arousal, oriented name. The scan. Sorry, obviously start with scan always.
Yeah. So
CT.
yeah, so we end up getting a CT. So here's what you see.
Oh wow. It's like a supracellular, maybe like I don't know. That's like hypothalamic, maybe. Large, like I want to get an MRI, but it's like that's like a ring, maybe cystic structure.
Yeah. Okay, good. And then we'll turn it over to David so you can go around.
Okay, cool. Thank you.
David, so now that you see this, when the patient's somnolent, what would you do? Would you just
Eva. Sorry, I missed this part. You said the patient's coming in through the ER. This is an outpatient.
Oh yeah, here, let me give you the patient came in through the ER, had altered mental status for the past 2 days. Here's his past medical history, and he's somnolent but arousable, oriented to name, and then intermittently following commands. So you get a CT, and this is what you see.
Yeah, there's it's clearly obstructing the foramen Monroe. There's evidence of obstructive hydrocephalus here. There's like this patient. There's an indication for CSF diversion.
Mm-hmm.
In this case, I would want to do an EVD. The other consideration you could do is always you're considering doing like a ETV with biopsy, given accessibility to the tumor.
Yeah. So then we ended up getting an MRI as well. And so can you describe what you see on MRI?
Yeah. So you have a contrast enhancing third ventricular lesion that has a cystic component that's CSF isodense and T2 hyperintense with some surrounding vasogenic edema in the thalamus.
Mm-hmm. And then, do you think it's like intraventricular lesion or is it like intraparenchymal?
I think it looks like it's an intraventricular lesion. Actually, it's kind of.
And then I'll show you the coronal. Actually, so here's the coronal.
I take that back. It's actually intraparenchymal.
Yeah. So it looks like it's at the thalamus, the pulvinar area. And so so what is your differential?
Yeah, so for my differential would be in this case primary would be something like a glioma, like a midline glioma.
Mm-hmm.
Other things considered less likely, but you can always consider something like a MET. Let's see.
So then, what would you do for this patient? Would you, do surgery? So you already put an EVD in. Then now would you do surgery? Would you do a biopsy and lit and then shunt them? No.
So in this case, if it's a right side thalamic lesion, obstructive hydro, you can consider doing surgery. Obviously, if they have an EVD in place, they may be reliant on CSF diversion. Consider doing like an ETV with a biopsy. The other consideration is also doing lit with the biopsy. I wouldn't necessarily be aggressive about doing surgery for resection of the mass, given its location. Would need to know his prognosis overall as well.
Yeah. So what we ended up doing is surgery. So you could, so for a biopsy and lit, it's an alternative in which some people would do, but the only thing is that it would not remove the mass effect in the beginning, and then it would require the patient to have a shunt, and so then what we ended up doing is a right superior parietal lobule approach, and then save that cystic area for last. And we just planned on an intentional subtotal resection just to, relieve the mass effect and to help with the obstructive hydro. And then the other approach that you could consider also if it was something like an intraventricular meningioma, or you could go from below, if it was in a slightly different location than this, which I'll talk to you about later. But so we didn't end up doing this we didn't end up going through the superior temporal drivers just because you would have to traverse through the internal capsule, which you see here. And so here's the post-op scans. And so we ended up doing a subtotal resection, like I said. And then it looks like the ventricles came down. And so we'll turn it over to Dr. Saad for the path.
Okay. So this is the tumor. The tumor is very cellular. And here you can see an area of necrosis. So every time we see necrosis, it is an alarmic feature, and it tells us most likely we are dealing with a high-grade tumor. The tumor is, as I said, very cellular. The background or the stroma is myxoid. That's why it appears a little bit bluish. The tumor cells are mostly oval to spindle-shaped. And this is an area where you can see mitosis. This is atypical mitosis. And there is significant atypia and pleomorphism, which means variability in size and shape of the nuclei. The first thing to rule out, obviously, is a glioma, and this was ruled out by the negativity of GFAP. Here you can see some entrapped white matter, but the tumor is negative, and OLIC2, which is a pan-glial marker, is negative. H3K27ME3, which is a stain that we use for MPNST, this stain is positive in normal tissue. However, it is lost in MPNST. So here, if you look at the nuclei of the tumor cells, they have lost the expression of this particular marker. And the positive cells that you see are endothelial cells of small capillaries, which are very useful because it provides us with good internal control. So this is a case of MPNST intermediate grade.
Sorry, let me share my slide real quick. So yeah, so like what Dr. Saad said, this was an MPNST, and so these are mesenchymal neoplasms that originate from peripheral nerve sheath or from the differentiation of schwannomas or plexiform neurofibromas, and so the majority occur in the periphery, the trunks, or the limb, and only 5.1% occur intracranially. And so when it's intracranial, most of them arise from cranial nerves, and the rest are just intraparenchymal MPNST, which is like ours, which is also called malignant intracerebral nerve sheath tumor. And so they have a pretty dismal prognosis, median survival of 9 to 11 months, and 1 year survival of 33%. And so here's what I saw in the literature. I thought it was kind of interesting just because it's not a typical thing that we see. And so for intracranial MPNST that are not associated with cranial nerves, the origin of where they come from is uncertain. And so I also found that they lack a pathognomonic radiologic appearance, and so they usually look like contrast enhancing lesions like ours that are loculated and they have calcifications. And so when they're intraaxial like that and in the thalamus, initially what we thought was that it was probably a high-grade like a thalamic glioma, but here it actually shows that it can actually be mistaken because it can look like a high-grade glioma, but it actually isn't. And so MR spectroscopy, which we didn't do, can actually differentiate the MPNST from gliomas. And so a high choline peak with an absent N-acetyl aspartate is how you can differentiate MPNST from gliomas. And so just a quick thing, for MPNST, it stands for S100, but then for other spindle cell sarcomas, it's negative for these other stainings that the other spindle cell sarcomas have. So then the next case is, I guess we can ask, is Long here?
Hey, Eva, I'm here.
Okay. So it's a 62-year-old woman who had 2 years of difficulty ambulating, has a history of breast cancer and GI cancer that's now in remission. And then, on exam, she has a shuffling gait, but otherwise is intact.
Okay. So she has difficulty ambulating. Does she does she have any myelopathic signs?
No. No hyperreflexia or anything.
Okay, I would probably, if she doesn't have any myelopathic signs and she's neurointact, I'll probably just start off with a CT head.
Okay, so here's the CT.
So I see a CT head axial or right hyperdense lesion that's periventricular. It actually appears mixed density. Some parts of the lesion appear isodense to brain. The periventricular portion appears hyperdense, potentially suggestive of some calcifications. I don't see any evidence of any obstructive hydrocephalus on the CT scans here.
Yeah, and so they ended up getting an MRI, and so here's the MRI.
Okay, so looks like axial T1 with contrast, and T2. On the T1, the lesion appears isointense to brain. On T1 with contrast, the lesion, of course, appears heterogeneously contrast enhancing. Lesion appears hypo, and there's areas of a hypointensity on the T2 scan. Yeah, I think likely, the differential for this lesion, probably top of my list would be intraventricular meningioma. Less likely, potentially like a high-grade glioma, and of course, MET would also be on my differential given the cancer history.
Yeah, so then, here's just a list of differentials for tumors and that arise and that are in the atrium. And so for kids, you would think also about choroid plexus papilloma. And then for, mid-aged people, you would think about ependymoma, oligos, or low-grade astrocytomas. And then for, older patients, you would think about MET and meningioma and lymphoma, like what you said. And so is Victor there? Or is Damien there? Okay.
Yeah, I'm here.
Oh, okay. What would this lesion is like around, a little less than 3 centimeters, would you do surgery, or would you do radiosurgery, or just watch the lesion?
No, definitely wouldn't do radiosurgery or watch, even having symptoms. It's a pretty large lesion, and on the right side, so definitely accessible. As far as and she's like 60 something, so she's not that old. I think surgery is a reasonable option for her. As far as and we're not exactly sure what the diagnosis is too, so like getting tissue will be beneficial. As far as approach, could too high to do like subtemporal. You could consider maybe like a Vicor, kind of a transcortical. Probably have to see some other cuts to kind of get a better idea, but probably going like superior temporal gyrus to get there, as opposed to last case, is more reasonable this time around.
Yeah. So for like what you said, for the intraventricular meningiomas, usually they get their blood supply from the colloidals, and so that's why we ended up going, instead of like the other case, we went from superior parietal lobule approach, but for this one we actually went through the superior temporal gyrus posteriorly, just so that we could get early devascularization first, which the superior parietal lobule approach wouldn't let us do, and also for that superior parietal lobule approach would also have a really far reach. And so also, so you can go either through the superior or the middle or the inferior temporal gyrus. And so if it's on the left, we would favor, going through the inferior temporal gyrus just for speech. Yeah, so here's the post-op scan. And so you can see here, we just went through the middle temporal gyrus actually. Oh, and then we'll turn it over to Dr. Saad for the.
Okay, thank you. Okay, so this is a meningioma. So all what you see here are meningothelial cells, and they have this vaguely fibrillary background. There is minimal ATP and pleomorphism, no necrosis, and no mitosis. This tumor shows extensive calcification and ossification. These are distinct from some moma bodies, which I'll show you a picture of. This is just dystrophic calcification / ossification. And you can see the meningioma is present in microscopic foci in this particular section. And this is some moma body. Basically, it's a laminated, circle of calcification. And then you have the meningioma in the background. The tumor cells are EMA positive, like all meningiomas, and Ki-67 is about 1%. So this is a meningioma WHO grade 1.
Okay, so yeah, so this is a meningioma. So usually they arise from arachnoid calf cells. They occur more commonly in female than males, and then associated with chromosome 22. And so, typically they have like the moma bodies and then this whorled pattern, like what Dr. Saad was talking about. And so here, just wanted to show, there's different types of variants of meningiomas. And so some of these ones on the left are like the WHO grade 1 ones. And then if it's like atypical clear cell or choroid, then it's WHO grade 2. And if it's anaplastic papillary or rhabdoid, on the histology, then it's grade 3. And so, yeah, so that's it.
Okay, thank you, everyone.
Eva, this is John Ragab. I can't help but comment on your approach on the last case. You are correct about the vascularity issue, but what you give up is the superior quadrant defect associated with that approach through the superior temporal gyrus.
Mm-hmm.
And although you may consider that insignificant, it's just one of those things to keep in mind.
Mm-hmm. Thanks.
So, well, it's a pleasure to present in grand rounds again, and I'm going to, it's an idiosyncratic presentation. It's a personal journey, and its topic is on the role of cerebral blood flow related to adenosine, a compound that I was involved in the definition of its role for over 40 years. But first, let me talk about some general principles in regard to cerebral blood flow regulation. And that is that cerebral blood flow, or its inverse, cerebral vascular resistance, occurs in hypoxia, ischemia, hypotension, and neural activation. And these entities can be grouped into whether there's a decrease in supply, which would occur in the hypoxia, ischemia, and hypotension. And one could say is a decreased supply of oxygen, or the alternative, like in economics, an increase in demand. I suspect we're all now very sensitive to the rules of economics with the supply chain, but that the increase in demand would be seen with neural activation, whether it's seizures or simply what I hope most of us are continuing to do, and that is when you're alert, moving around, any kind of neural action locally, very specifically increases energy demand. And there are three classical hypotheses that were developed to explain how the brain, and for that matter, any organ in the body, regulates its own blood flow. The first is the neural hypothesis, which states that they're nerves that actually control flow, for example, in the brain, and that this is the determinant of matching flow to metabolism. It was a popular theory, and actually, when I got started in this area in the 70s, was hotly investigated, but quite frankly, the data supporting the neural hypothesis is not extensive. Then there's the myogenic hypothesis that states that the blood vessels throughout the body have an inherent tone that's preset. So when pressure, for example, or perhaps flow goes down in the lumen, the vascular smooth muscles, through some mechanisms, sense that change and would dilate to increase flow to an area where the pressure might be low or the flow might be low. And this hypothesis appears to be one that can explain some aspect of flow regulation in all organs in general, but cannot account for the diversity in flow that's seen in the brain. And then lastly, there's the metabolic hypothesis, and this shows you a paper done by Roy and Sherrington in 1890. Sherrington, as perhaps many of you know, went on to win the Nobel Prize in Physiology in 1932. And here's what they wrote at the time. The chemical products, and unfortunately, let me see if I can, the chemical products of cerebral metabolism contained in the lymph, which bathes the arterioles of the brain, causes variation in the caliber of the cerebral vessels. And in this reaction, the brain possesses an intrinsic mechanism by which vascular supply can be varied locally in correspondence to local variation in functional activity. So this is the metabolic hypothesis, and that is, as metabolism goes up, somehow the brain parenchyma is able to signal the cerebral vessels, and that they will dilate in response to increased metabolism, and in contrast, and importantly so, that when metabolism is decreased, the vessel and flow will decrease in caliber. Remember also that flow regulation in any organ in the body is primarily dependent on the smallest arterioles, those at about 100 microns or lower, principally the 40 micron vessels. And the vessels that we would routinely see in surgery, sometimes to our consternation, are the large vessels that are on the surface of the brain or deep in the brain, the middle cerebral, the named vessels. Those vessels are conductance vessels. They conduct flow. They dilate or contract to a very limited fashion in response to changes in metabolic activity. It's the smallest vessels, the 40 micron to 100 micron vessels, that regulate the flow. So if we stick with the metabolic hypothesis, there are a variety of compounds that have been proposed over the last 50 years or so, maybe even 70 years. And here are the usual suspects. Oxygen itself, since it's presumed that oxygen limitation is responsible as the signal for alteration in flow, and you would that came from the idea that during hypoxia, blood flow increases. But the reality, oxygen itself is not a very active agent. CO2 and pH, of course, we in neurosurgery recognize the profound effect of CO2 and to an extent pH on blood flow. But that, again, is hard to tie to metabolism. Potassium also proposed, potassium is a vasodilator, but it's also a constrictor at high levels. And most studies do not lend support to the sense that potassium is the messenger, but there are still advocates for the potassium as a metabolic agent. And then there's NO, nitrous oxide. That had a real flourish of attention. I think in the 1980s, it was picked as the molecule of the year. A lot of work went on, but that has not stood up to rigorous testing. And then lastly, there's adenosine. And let me give you a little, well, you might ask, well, how did you as a neurosurgeon get involved in this? And it was really that I, as a resident, was very interested in vasospasm, which was, of course, a major problem, poorly understood. And I was expressing this interest to John Jane, who was the chair at Virginia where I trained. And he said, well, go over and talk to Bob Byrne. And John and Bob Byrne used to play tennis Tuesday nights, and the residents as a rotation were assigned to be ball boys. Of course, there were no women in the program at the time. And of course, I'm kidding, but that's how I got to know Dr. Byrne. I went over to his office. He was the chair of physiology. And I said, you know, I'm very interested in vasospasm. And he listened to me for a while. And then he said, that's very interesting, Dick. But look, why don't you think about studying how the brain regulates its blood flow? So 40 years later, 50 years later, I never got back to what my intention was to study, but I spent a lot of time. I spent 8 years with Dr. Byrne in his lab, and subsequently had my own independent lab, which was focused on the role of adenosine in blood flow regulation. Bob Byrne was a remarkable guy, member of the National Academy of Sciences, Harvard Medical School, did his internship at Sinai, then went out in World War II to the Pacific, came back and finished in cardiology, and then decided that he really wanted to spend his life in investigation. And after a distinguished career at Case Western Reserve, he became the chair of physiology at the University of Virginia. Here's this paper, seminal paper, which he published in 1964 on cardiac nucleotides in hypoxia. And he articulated the adenosine hypothesis to explain myocardial blood flow. Here I am as I guess I was like an R4, just before I went into the Army with Dr. Byrne in his laboratory. You can see a sheep here in this instance, and here's his lab technician from whom I really learned a tremendous amount of physiology. So let's look at the criteria that have to be fulfilled if a compound is going to be proposed as a regulator of blood flow. This is that the affected organ, number one, should be capable of producing the proposed regulator substance. That's self-evident. If the organ doesn't produce substance X, you can't propose with any seriousness that it's going to regulate blood flow in that organ. Two, the regulator substance must be a vasoactive agent. Again, obvious. Three, metabolic activity that increases blood flow should correlate with the production of the regulator substance. So if some challenge occurs, flow goes up in an organ, in this case, the brain, and you're proposing a metabolic regulator that goes up, but it goes up 2 minutes after flow goes up, well, then temporally, it's not a good fit. And probably rules out that substance as a regulator. And conversely, when flow goes down after a challenge, you need to see that that metabolic regulator then also decreases and not persists. Otherwise, the flow, if it's the regulator of flow, flow would continue to remain elevated. And there's a fifth criteria that we proposed back in 81, which I'll get back to, but it's really the key factor. So what about adenosine? And so here's the adenosine has two prime roles in the central nervous system. One, it modulates neuronal activity, and it really causes the brain activity to decrease. In fact, some people have proposed, since adenosine is up during sleep, that adenosine is a sleep factor, although we know the brain really, metabolism may change some, but the brain doesn't go really to sleep. The human goes to sleep. In any event, production of adenosine occurs in its neural role in this cycle where homocysteine, methionine down to SAM, which stands for S-adenosyl methionine. And as it is broken down, there is this methylation production. And it's this cycle and this pathway that breaks down neurotransmitters in the cleft. Every time a neurotransmitter is excreted from the end plate and is not rapidly taken back up, this cycle is generated and there is a obligatory production of adenosine. But that's in the cleft, and it is a long way from a passing arterial, maybe not in distance, but it goes through really hostile territory where adenosine would be metabolized. So let's look at the topic, that is the regulation of blood flow. Here's where adenosine comes from in the proposed role of adenosine as a regulator, and that's through the breakdown of ATP through ADP to AMP. These are adenine nucleotides. Adenosine is a nucleoside, which means it's got a ribose base and a moiety attached to that ribose base. So here's what, and again, as I apologize, a very personal visit, here's what we found in regard to the brain and adenosine and blood flow regulation, and I'll present the data in more detail subsequently. But number one, topically applied adenosine causes PL vessels to dilate and results in an increase in cerebral blood flow. So it is, and how did we come to this conclusion? Well, we did in vivo studies, but here was a technique, and many of the things I'm going to tell you about was pointed towards investigating the role of adenosine, but required quite a long startup period of developing new techniques, testing these techniques, and assuring that whatever we were. Let me turn my phone off here. Assuring that whatever intervention we were going to do to test our hypothesis, that it was a pure stimulant or deficit and that it wasn't causing other effects. So we proceeded actually to borrow from the renal nephrologist this technique and modified it so that we could use it in cerebral vessels. We could take out the penetrating vessels that go down through the Virchow-Robin space, 40 micron in diameter, as you'll see, and we were able to perfuse them as shown here. We have two pipettes, and here's the cartoon. It's about 40 micron in diameter. You would be able to alter flow. You can alter external diameter. You can alter the composition of the extra at the abluminal and intraluminal concentrations. So in regard to adenosine, we found this dose response curve. Here's percent diameter. Here is the curve, the response curve, and you can see it's sigmoidal. But interesting, this is the area where small increases in adenosine should increase diameter most dramatically. And that's in rat, it's in mouse, we did some in humans. And it is this sharp, high rising compartment of the curve. You can see that here, small additions of adenosine would cause more dramatic increases in vasodilatation. Remember, flow varies to the 4th power of the diameter of a vessel. So these would be small amounts of change in adenosine surrounding an arteriole would have a rather profound effect on diameter and flow. And if resting levels of adenosine were down here at -9, -8, or conversely very high in higher concentrations, then that might potentially say, wait a minute, there's a problem with this hypothesis. But when we measured CSF and interstitial fluids, we found, as shown here, that the levels were in the sharpest part of the rise at about 10 to the -7. And in addition, this technique allowed us to discern, well, is adenosine effectiveness highest on the extraluminal or intraluminal surface of the vessel? And you can see here the extraluminal, which then would be facing the parenchyma of the brain, the glia and neuronal elements, or the intraluminal. And it turned out, as one can see, that the vasodilatory actions of adenosine were diminished in intraluminal compared to extraluminal. And we looked at many other purported regulators of flow. Here's just one, which I didn't mention, but ATP. And what you see, it's just the opposite. The most potent vasodilatation when ATP is applied is not abluminal, which, that's the active side of the brain in regard to the vessel. It's the intraluminal. So this again suggests that, well, maybe ATP is not a regulator. And in addition, others defined during the same period of time that adenosine had specific receptors. The A1 receptor was in the nanomolar sensitivity range. It caused decrease in cyclic AMP and inhibited the release of excitatory amino acids. That goes along with the fact that it regulates neuronal activity. In contrast, the vascular elements involved in adenosine regulation, there are 2 receptors, the A2 and A2B. These, in contrast, increase cyclic AMP. It's a vasodilatation, as you have seen, and it's the sensitivity is a little higher in the micromolar range. So now we go back to the same experiments I showed you in the vessel, and we apply adenosine here. We see a rather vigorous vasodilatation. And now in yellow is adenosine plus ZM, which is an A2A blocker. And you can see there's considerable attenuation, suggesting that the primary mechanism for vasodilatation on vascular smooth muscle in arterioles is through the A2A receptor. So I told you that topically applied adenosine causes PO vessels to dilate, that is the penetrating vessels. Intravascular adenosine has no effect on CBF. That, again, it's the abluminal surface that's active. So a blood-brain barrier exists for adenosine. It can't get through the barrier. adenosine is not metabolized in CSF, and therefore adenosine released into the CSF or interstitial fluid is reincorporated into brain nucleotides by adenosine kinase. What those two sentences mean is it's tightly regulated in the brain, in the extracellular space, as it is in almost every organ in the body. And then now we get into the physiology, and that is increases in brain adenosine concentration correlate temporally with the changes in cerebral vascular resistance and cerebral blood flow during ischemia, hypoxia, and seizure. Let me just show you some of this data. And here's the experimental paradigm that we used, and actually revealed one of the very few advantages in those days of training in general surgery prior to going into neurosurgery. In those days, general surgeons were doing lumbar sympathectomies, and consequently, as a resident, I learned early on how to do a retroperitoneal or a properitoneal, not to mix up Greek and Latin, approach to the thoracolumbar spine. And I remember well that the chief resident would be circulating while I was doing an operation saying, Dick, be careful. Don't cut that big red pulsating thing. Don't watch the vein, the inferior vena cava. And so it was this approach that we utilized to make a square wave change in blood pressure. We could have considered just giving a blast of potassium, which would stop the heart, but the diminution in blood pressure is really fairly prolonged. I was interested in seeing how quickly did adenosine change in the brain during ischemia, because if you make the animal ischemic, the cerebral vessels dilate within 2.5 to 5 seconds, at most 7 seconds. So I put a suture around the aorta, a stainless steel suture, brought it out through a needle, and pushed the needle. And here's what happened. You can see that this is blood pressure, that we achieved almost zero flow within 0.2 of a second. So that was a square wave change that then allowed us to go on and study in the first 5 seconds the changes in flow. Now, we then needed a way to get the brain out rapidly and in a way by which metabolism was stopped. And we used this machine developed by Bud Veach. It's called the Brain Blower. This occurs because you have two needles, stainless steel needles of a large caliber, mounted on powerful solenoids, and you press a button, the solenoids are activated. These two probes crash through the skull simultaneously of the rat. Compressed air is then activated, blows the entire supratentorial compartment of the brain across these aluminum plates, pre-cooled in liquid nitrogen. And if you want to see the neuroanatomy of the rat brain looking like a pancake or a latke, here it is. And now here are the results. So we had a variety of control groups, awake, anesthetized, sham treated, and then at 0, 5, 10, etc. seconds of ischemia. And you can see that adenosine is significantly elevated at 5 and 10 seconds, and then subsequently goes up. This reflects the late breakdown in ATP. This is the same curve, and I'm going to show you other compounds we studied, some of which had been proposed as flow regulators. Here's phosphocreatine. That's not a vasoactive compound. It's really the source. It's a bank of ATP. Here's lactate, which had been advocated by Fred Plum and Bo Sejo as the regulator of flow. You can see lactate rise is behind not only the rise in adenosine, but by then the vessels are dilated. Here's energy charge, another proposed regulator. Here's ATP, which remains elevated for 30 seconds after complete ischemia. That's principally because phosphocreatine is degenerating and cleaves off one ATP, which then maintains ATP intracellularly. So in that regard, adenosine, the temporal changes in adenosine are consistent with the observed changes in cerebral vascular resistance. Next, we looked at hypotension. To look at hypotension, we had 60, 80 rats. We dropped an individual rat, 10 millimeters of mercury, 20, and so forth, all the way down within and below the autoregulatory range, which is usually said to be 140 to 70. And here, this shows some data, but you can see as the pressure drops from 135, 170, 107 to 72, that we get increases, statistical increases in adenosine. We did not find similar significant changes in any of the other compounds measured, which included all the adenine nucleotides, lactate, and so all the usual suspects. So that's ischemia, hypotension. Now we turn to hypoxia, but again, as I alluded to earlier, we had to develop a technique that would allow us to measure flow rapidly. And we developed this technique that had previously been tested but not widely used. I was a young lad in those days, and I didn't have a lot of grant support when I was just getting started, and I couldn't afford the more expensive ways, microspheres and so forth. And so we developed this technique where we would measure blood flow out of the transverse sinus of the rat, called the retroglenoid vein, and it would come out and you'd count the drops. This is a drop counter, and you can see as the rat gets more hypoxic, the number of drops increases. We documented that the drop size didn't change depending on the rate of the droplets. And then we return the blood to the rat, and this was an anesthetized rat, monitored, temperature monitored, and so forth, anesthetized. And in order to achieve a square wave change in arterial PO2, we use this 2-respirator technique. One respirator, high oxygen, the other with 100% nitrogen. The rat respiratory rate is about 180. It's very high. The heart rate's about 360 to 450. So you can rapidly alter brain PO2 by having them breathe 100% nitrogen. So here's the PaO2 in the rat. We gave the challenge of 30 seconds breathing the 100% nitrogen. You can see the PaO2 starts over 100. By the end of 30 seconds, it's at 26. And then we restored back to the first respirator, and oxygen in the blood rapidly increases. Here's the changes in cerebral vascular resistance, which is the inverse of flow. So flow would be going up like this. And what you see is that the vessel diameter increases in size, flow increases consequentially, and within 15 seconds, there's a statistically decrease in cerebral vascular resistance, which persists. And then with the return of oxygen, flow or cerebral vascular resistance returns towards resting state. Then we go back, different animals blow their brains out under the same paradigm. And you can see that the changes in adenosine, now plotted in this lower graph, are the mirror temporally the changes in flow during acute hypoxia. So again, another bit of evidence that positively supports the role of adenosine in cerebral blood flow regulation. And what we were trying to do was, build this structure that adenosine was a significant contributor to cerebral regulation. Here's a more modern approach that we address in this situation, same experimental paradigm, but instead of measuring flow through a retroglenoid vein outflow, we now measured flow with Doppler and adenosine with adenosine electrodes and inosine electrodes. It's the first breakdown product of adenosine. And as I said, with laser Doppler. And here's what we get in this situation: cerebral blood flow and adenosine. Adenosine is plotted here. Again, we're using adenosine electrodes, and you can see that adenosine is changing within milliseconds of the change in PaO2, which mirrors and perhaps precedes the increases in cerebral flow. Again, further confirmation that in hypoxia, adenosine could fulfill the criteria for being a regulator of flow. So I talked about ischemia, hypotension, and hypoxia. As I pointed out earlier, there are situations where there's a limitation of supply. How about the opposite? Increased demand. And of course, the most severe form of demand is with seizures. Here's a study by Meldrum and Nielsen, a classical study in 1976. And you can see here, they seized the rat in rats with bicuculin. And here's the cerebral blood flow, a really dramatic, almost 8-fold increase in flow. We, using the same experimental paradigm and using our brain blow technique, here we measured adenosine after the onset of seizures, 10 seconds, 20 seconds, and you see this curve. Again, the temporal profile is supportive of the concept that adenosine is changing rapidly enough and decreasing rapidly enough, the rats continue to seize, to be considered as a serious contender for a regulator of cerebral blood flow in the brain. So I showed you these criteria right in the beginning of my talk of what a metabolic regulator of flow in any organ should fulfill. And I said there was a fifth one. And the point is that all of these and all the evidence I've presented so far only show correlation between flow and adenosine. Here's the fifth criteria, and that is specific blockade of the presumed metabolic regulator should ablate or diminish the expected vasoactive response. And also something that would accentuate the flow, accentuate the amount of adenosine should increase flow. And I'm going to show you the data for that, but the compound we turned to is the most widely used drug in the world. And I suspect 98% of those attending grand rounds utilize this drug. And that is the methylxanthine, caffeine, or theophylline. And the methylxanthines have three effects. They're phosphodiesterase inhibitors. They cause the release of catecholamines from the brain, but that occurs at much higher doses than the third action of methylxanthines, and that is adenosine receptor blockade, which occurs at below 10 to the -4. So first, we had to, in rats that hadn't been described, achieve levels that were not above 10 to the -4. And this just shows the levels in plasma, it's 10 to the -4, and in CSF. We had to show that even if you treated the rats with theophylline, we chose theophylline, that it would not interfere with independent vasodilators, such as CO2. And here you see control animals, and here animals pre-treated with theophylline, and they have the same response. So theophylline in itself is not paralyzing the blood vessels so that that's why you don't see a response. It appears, at least, and we did a number of other stimulants to flow that were not adenosine related, we thought, and did not find interference. So it seems like it's a pretty isolated probe that we could use. Here's the first set of experiments we did, and we did them with sustained hypoxia. And in this case, we used microspheres, a very tried and true method for measuring blood flow. Here's the control. You take a rat in normoxia, drop the PaO2 to 40 to 50, and then here 30 to 40. And here's what happens when you pre-treat them with theophylline, significant differences at both levels. And this is just to show the vessels that we were looking at. We had to create a model, again, another building block just to look at one aspect of adenosine. We developed the technique of cranial window in the rat. And as you see, here's the vein, here's the arterial, and you can see here's 50 microns. So this is about a 30 micron vessels, and these are even smaller. Here's during 15 seconds of hypoxia. You see the vein doesn't change, but here is the arterial, and look at the dramatic difference. Now we then, using that technique, we look at hypoxia in the control. We get about a 30% increase in flow. And now we add, this is theophylline given IP, and you can see that it blocks down in a dose response manner the vasodilatation during hypoxia. So that's if we block it. How about if we accentuate adenosine? And as I told you in the initial comments I made, adenosine is not broken down in CSF. The only way you can extinguish adenosine in the interstitial fluid or CSF is by taking it back into cells where it is reincorporated to ATP or broken down to hypoxanthine. So if there's some way that you can block the transport of adenosine, which is excreted into the interstitial space, as we've shown occurs during hypoxia, you should get an exaggeration of the vasodilatation. And the drug we use is a widely used drug, dipyridamole. And here's what we see. Here's vasodilatation with MOX-CSF, about 25%. Here's in the presence of dipyridamole, an exaggerated effect. And now we can block this effect. In other words, dipyridamole and theophylline down with theophylline, showing that this effect is really related, the exaggerated effect is related to dipyridamole's inhibition or attenuation of the uptake of adenosine. There's more adenosine than in the interstitial space. Here's a more modern replication of that study. Here we're using wild type mice and A2A knockout mice. And we're measuring flow with a laser Doppler, the same paradigm. We make the rat transiently hypoxic for 30 seconds. Here's flow increase during that 30 seconds. It peaks and then rapidly comes down. And here's what happens in the knockout, the A2A knockout. You can see a significant diminution, blue versus orange. And now, so that's hypoxia. What about hypotension, which I showed you earlier? Again, it was correlative rather than definitive. And so we investigated the autoregulatory response in wild type and knockout A2A rats. And here is the autoregulatory phenomenon demonstrated. We have a rat anesthetized, respirated, etc. And we have a femoral artery catheter, and we withdraw a volume of blood. The blood pressure, shown in red, drops fairly dramatically, but we're measuring flow with the laser Doppler. Flow is preserved to a much greater extent compared to the dramatic change in blood pressure. and then we restore it. Blood pressure comes back up, and flow then returns rapidly to normal values. Here's what happens in the A2A knockout. And what you see is passively, cerebral blood flow follows blood pressure. There is no autoregulatory action in the A2A knockout in comparison to the wild type, which again suggests strongly that that adenosine is somehow related to autoregulation. So everything I've shown you so far really focuses on decreased supply. Let's look at increased demand other than seizures. And we developed this experimental paradigm shown here, where we would stimulate the sciatic nerve and look at one arteriole and sensory hind limb cortex. This took a long runway for us to get to the point where we could really study what we were interested in. We had to develop this model. Took us about 7 years, but here it was. It was a respirated rat, anesthetized, arterial pressure monitored, a cranial window prep so we could look at hind limb sensory cortex. And then we dissected out the sciatic nerve and we stimulated it. But before we got started looking at adenosine, we had to define the correct stimulus frequency, including stimulus and strength. And then we could see here's the SEP, and here is sensory hind limb cortex. And as we move distant away, you cannot record the SSEP as well. And this is then shows the vascular response in a 40 micron vessel. And this is a fast paper speed. So you see it's a 20-second stimulation, takes a few seconds for the vessel for us to show statistically that the artery is dilating, and it peaks and then returns to baseline. Here's different stimulation periods, 10 to 60 seconds. And what we subsequently proposed was that this was some type of reflex. Whoops, let me go back one. But this shoulder was the metabolic component. Here's the cranial window. Here's the sensory hind limb cortex. I'll show you. Here's the vessels going to other areas of the brain. And here we see at 15 seconds, here's a vein. Here's normoxia. Here's hypoxia. Again, this is 50 micron bar. Here's the feeding vessel to A. You can see even that dilates, whereas C and D, distant to sensory hind limb cortex, is gone. Here's a video. Vein, very small artery, sensory hind limb cortex, and boom, we start the stimulation, and there's a rather dramatic increase in flow, in diameter, which of course has a profound effect on flow. We stop the stimulation, and you can see a rapid return to baseline. That's going on in all of our brains, hopefully. Just hearing my voice in auditory cortex. We also use functional MRI to localize hind limb cortex. Here's a different way that published with Mike Haglin, looking at optical imaging. And this is just to show the focality of sensory hind limb cortex. It's quite small. You're going to see it. Now we start stimulating, and here the cortex. This is about 1.5 millimeters from top to bottom. So we had the model, we defined the model, and then we went back and then started testing with theophylline, caffeine, and so forth, the effects of the vasodilatation during sciatic nerve stimulation. And we noted that theophylline in itself and the dosage we used did not affect the SSEP signal. Here's with MOX-CSF, vessel diameter here, no theophylline. Here's with topical applied theophylline, you can see the diminution. Then we wash it out, return to CSF, and boom, it returns to baseline. And here's the sum data. Here's the control values of vasodilatation lasting 20 seconds stimulation. It returns to baseline by 30 seconds and about a 35% increase. And here's the sum data, I think N of 8 or 10. You can see there's significant diminution both in extent and duration. And dose response curve for theophylline, caffeine, and so forth. Here's the specific A2A compound ZM, and you can see these are vasodilatation during sciatic nerve stimulation, 1 arterial 40 microns, and now it's blocked down by this A2A blocker. And here's during dipyridamole, you can see control response and then a significant augmentation in adenosine related vasodilatation as the adenosine that's excreted from the cell it is no longer avidly taken back up. It hangs around longer. Therefore, we get a greater vasodilatation and a longer effect. Here's the most recent studies. Now we're using knockout, just as I showed you in hypoxia and hypotension. Here's the control. Let me go back. Control animal. Here's the knockout. And we think that it's not as clear because in the knockout animals, for these prolonged studies, the A2B receptor, which is known to have some vasodilation action, is playing a role. Then in the closing few minutes here, I want to talk about a slight change in what we were trying to determine, and that was where is the source for adenosine that's involved in vasoregulation. Cerebral vascular endothelium, we found, did not play a role, so we ruled that out. And next, it's been known that neurons produce adenosine, as I showed you earlier, but astrocytic production was unclear. We developed, as it says here, previous cellular studies were limited by monocultures and low ratio of tissue to medium. So therefore, we developed a new way to harvest these cells and get a greater volume of cells so that we could discern changes at lower levels. And what we found, here's astrocyte cultures in which we did step decrease in oxygen. And then as you can see, a significant response here as compared to 160 and 30, all the values were significant. And just to remind you, A shows the resting oxygen level in brain tissue, and B shows the levels that we found of adenosine in brain. So again, the steepest part of the curve is where we see resting levels. And here, which goes back to this original curve I showed you on the isolated vessel. And C is the levels of adenosine found in brain during hypoxia. So again, this fits with our hypothesis. Here's the temporal profile of the production of adenosine in astrocytes. This is a study from GLIA, published in GLIA. And it's very hard to achieve a square wave shift in oxygen in a culture. It's got to diffuse through the culture medium and so forth. But rather than seconds, it takes perhaps 60 seconds for the PO2 to drop. But we see a rather brisk and rapid increase in hypoxia as measured at 30 seconds and 1 minute. And in the same way with reoxygenation, adenosine plotted in green returns to normal. And just to remind you, here are the changes in hypoxia with cerebral blood flow and adenosine. So our findings in culture strongly suggest that it's a reasonable simulation at the astrocytes in vivo. So our conclusions were that our astrocyte cultures replicate adenosine in vivo during normoxia and hypoxia and reflect oxygen availability. So, I mean, it was very gratifying to see this publication in 2022, just last year, March, in Science Signaling, that reconfirmed many of our observations and others, that adenosine is a prime factor in vasodilatation and vasoregulation in the brain. And what these individuals from Vermont, the vascular lab, the University of Vermont, found that adenosine acting as on the A2 receptor was very critical for the signaling from the capillary bed up to the arterioles, the 40 micron vessels that can also play a role in invoking dilation and increase in flow. So in summary, in physiologic conditions, the data are consistent with the hypothesis that adenosine is a metabolic regulator. Adenosine concentrations in brain are elevated during ischemia, hypoxia, and neuronal activation. Alterations in brain adenosine activity affect cerebral circulation in the expected manner. Receptor blockade attenuates CBF, whereas increasing adenosine availability augments CBF. Astrocytes appear to be a major source of adenosine. In astrocytic cultures, adenosine reflects oxygen availability under static and dynamic conditions and are similar to in vivo. But fortunately, there's still work to be done. The factors responsible for adenosine production, i.e. the release, uptake, cellular, and biochemical source, and its subcellular actions remain unclear. And in closing, I want to thank the audience for their attention, but also acknowledge, I want to acknowledge the NIH who kindly supported me for 35 years in grant support, and all of these folks beginning back at UVA, and you'll note many of these folks are neurosurgeons: Tyson Park, Dennis Vollmer, David Weaver, Joe Welsh, Ralph Dacey. So that was at UVA, the University of Washington, bigger crew, but you can see neurosurgeons both in the United States and elsewhere. And then at Sinai, again, similar group of hardworking folks who I greatly appreciate their collaboration and work. And I thank the audience for their attention.
That was excellent, Dick. This is Roberto Harris. How are you? Just a great example of a systematic, progressive exploration of a single important question, adenosine. No wonder they call you Mr. Adenosine. Yeah.
Well, they call me a few other things that aren't so polite.
We won't mention those.
Thanks, Roberto. Good to see you again.
Good to see you.
Part of the reason I wanted to present this is because not at the University of Miami and several other places, the sense that research should be an important component of neurosurgery training, I think is slowly being eroded, perhaps not so slowly. But I think, it's a belief. There's no hard data on this, but it's a belief that it does contribute to the education of neurosurgery residents and neurosurgeons. I think neurosurgery now is unique that unlike many of our surgical colleagues in general surgery, ENT, orthopedics, the requirement or the expectation of performing research, either at the basic or clinical level, is not as strong as it was in the past. I don't, Roberto and
You
Dan.
know, yes, that's true. And the other more recent factor that is really
hours.
Yeah, that we've done it to ourselves is this business of allowing these enfolded clinical fellowships. You know, when you give the resident the choice of doing during the residency an enfolded year of spine fellowship that is going to allow them, when they finish a residency, to go into a very excellent position without having to do a fellowship. When you give them that choice versus spending a year or two in the lab, you gotta, you know, most people are not going to choose to spend a year or two in the lab. So I think that's something we've done to ourselves as part of having, increased the period of residency so much that it just becomes really very burdensome to have to do a fellowship after the residency. So by incorporating it within the residency, we're going to ruin the uniqueness of doing research during the residency in neurosurgery, which, as you implied, it doesn't happen in almost any of the other surgical subspecialties. It's obligatory period that we used to have of doing research during the residency. It's going away.
And you know, there's no question that enfolded fellowships were a good thing, but as with most good things, sometimes there are unintended consequences. And one of the unintended consequences, you know, I was the head of the first committee. It was such a pain in the backside initially because, you know, people were objecting to it and so forth. So I've suppressed the name of the committee. But the unintended consequences was that, research rotation has probably been diminished. So some good was achieved and not so good was also affected. But in any event, I appreciate the opportunity to talk about kind of a boring subject to many people, but nevertheless, I think it's something that, one, I enjoyed it. People would say to me, why are you doing this, Dick? And I used to say, well, knowing what they did, I said, don't you do the crossword puzzle every day? I said, well, this is my crossword puzzle. I like doing it, you know? And it's enjoyable. It was enjoyable, as you know, from your own research experience. You know, you have a question and you want to answer it, and it's fun. So in any event, thank you. Thank Alan. Thank everybody for letting me present this.
Thank you.